To continue what I was talking about regarding the cerebral edema, this is part 2 of my live video presentation about cerebral edema in clinical practice. I already mentioned the mechanisms and types and the etiology of cerebral edema. Let me finish by an important cause, and this is the last one to be mentioned, the last but not the least, is the cerebral edema in the context of acute hypertension or complicating acute severe hypertension, and this is the accumulation of fluid within the brain as a result of the disruption of the what we call the cerebral autoregulatory cerebrovascular autoregulatory mechanisms and failure of the cerebrovascular autoregulatory mechanisms in patients with acute severe hypertension, especially in what we call hypertensive encephalopathy and malignant hypertension. The pathology of hypertensive encephalopathy involves two important features: the development of cerebral edema, either focal or diffuse, and the development of cerebral microhemorrhages. So microhemorrhages or small bleeds and cerebral edema are the two important pathological features of hypertensive, what we call hypertensive encephalopathy. Cerebral edema as a result of acute hypertension, or acute hypertension as severe hypertension as a cause of cerebral edema. This is to finish and to summarize the causes of cerebral edema in clinical practice. About the clinical picture of patients with cerebral edema, patients with cerebral edema may develop any of a mixture of the following symptoms and signs, which I will mention. Number one, it depends on the underlying cause. There will be the clinical picture of the underlying cause. If there is infection, that is encephalitis or meningitis or subdural abscess, there will be clinical features of meningitis or encephalitis, or clinical features of cerebrovascular strokes, that is motor or sensory deficits, or problems in speech, or problems in walking, problems in the other abnormal neurological findings, depending on the cause and the type and the site of the cerebrovascular insult, whether ischemic stroke or hemorrhagic stroke. In patients with a traumatic brain injury, there will be other signs of brain trauma, and other evidence of trauma, to physical trauma to the other parts of the body, the chest, the bones, the heart, the abdomen, etc. That's other manifestations of thoracic and abdominal injury as a part of a body trauma. So the clinical picture of the underlying cause, and then the clinical picture of the cerebral edema itself involves mixture of headache, stiffness and the pain in the neck, nausea, vomiting, disturbance in speech, disturbance in walking, irregular breathing, disturbance in the vital functions. If there is the edema involved the brainstem directly or indirectly, there will be abnormalities in blood pressure, in pulse, in temperature, in respirations, and in respiratory rate and the respiratory pattern. Also maybe seizures, maybe disturbance in higher cortical functions, that is cognitive dysfunction, attention and concentration disruption and problems, and also disturbed level of consciousness, ranging from drowsiness through stupor up to semi-coma and coma, These are the seizures, as I mentioned, that is some sort of sensory or motor seizures or mixture of seizure disorders. These are all the clinical symptoms and signs of cerebral edema, but the most notable is the headache and disturbed level of consciousness. And disturbed higher cortical functions of the brain. So this is the clinical picture of cerebral edema, and as I mentioned, it depends on the type of the underlying cause. It depends on also the severity of edema, that is whether it is localized or generalized, focal or diffuse, and the rapidity of onset of the cerebral edema. And the underlying insult or etiology which caused the edema. So this is in short, the clinical picture of cerebral edema. Then we come to the investigations and how we assess the patient after physical examination, of course, for the detection and recognition of the underlying cause and pathology in patients with cerebral edema, a detailed neurological examination, fundus examination, and then we proceed. Of course, in fundus examination, we'll find the evidence of papilledema due to intracranial hypertension in patients with cerebral edema. Also, we might have abnormalities on CT scan of the brain, and we might also have to do MRI of the brain to detect the underlying cause, for example, in strokes or in tumors or in other signs of traumatic brain injury, and to detect the edema and the extent of the edema and the sequelae of the edema on the brain, whether the supratentorial or infratentorial herniation, etc. That is the underlying cause, and the complications of edema will be evident on MRI or CT scan of the brain. Also, we might have to do sometimes lumbar puncture in selected cases. So this is the investigations and the clinical picture in patients with cerebral edema. We might also, after that, proceed to do some blood tests to detect the underlying cause directly or indirectly, or to detect any possible complications. As we all know, pulmonary edema might complicate cerebral insults, that is what we call neurogenic pulmonary edema, and I talked about it. So the pulmonary complications and the cardiopulmonary complications of CNS disorders might be recognizable in some patients who develop cerebral edema also. So this might all occur together, the cerebral edema with the neurogenic pulmonary edema, especially in patients with severe systemic insults, with severe systemic inflammatory reaction inside the body, and the beginning of what we call the multi-organ failure. There will be failure of the brain, failure of the lungs and the heart, failure of the kidney, failure of the liver, failure of the blood with DIC, etc., depending on the underlying cause of this problem and the beginning of development and the progression of what we call a systemic inflammatory syndrome. Or the multi-organ failure. So this is in patients with cerebral edema, the clinical picture. The management will depend on, number one, the cause. We have to treat the cause of the cerebral edema, management of the cause. And then after that, management of the edema itself involves different measures. It might include what we call the hyperbaric oxygen, to keep oxygenation of the brain and to keep the neuronal function working, and to prevent any further deterioration and the brain death. We have to give what we call hyperbaric oxygen through usually an oxygen chamber, to keep oxygenation of the brain and to keep the neuronal tissue alive. Number two is also keeping the body temperature low, and this is what we call hypothermia, as a method of preserving the brain and preventing any brain deterioration due to the cerebral edema, so hypothermia. Also, we have to be careful with intravenous fluids, and here giving intravenous fluids in patients with cerebral edema needs special wisdom. The physician should choose or should select the right fluid and the right amount for the right patient, and this is very important rule. The right fluid, what fluid I can give to patient with cerebral edema which will not cause deterioration of the edema and will not cause more worsening of the cellular edema of the brain and cause any complications and herniation and death. So the type of fluid is very important. Sometimes you have to use what we call hypoosmolar fluids or hypotonic fluids, not isotonic or hypertonic, which might deteriorate the edema more. So the type of fluid is very important. The amount of fluid should be important. It should be the amount of fluid which keeps the hemodynamic status of the individual without deteriorating the cerebral edema and the accumulation of fluid in the brain. And this is what we call take care of the body and the brain will take care of itself. This is a golden rule. Take care of the body. Keep the hemodynamics of the body, what we call the intravenous hemodynamic support and intravenous fluid resuscitation, general intravenous fluid resuscitation by giving the appropriate dextrose or the appropriate saline, but it should be hypotonic and it should be of limited amounts to prevent any further deterioration of the cerebral edema. So selection of the fluid is very important. Selection of the amount of fluid is very important. Selection of the osmolality of the fluid is very important to prevent any further deterioration, again to repeat, any further deterioration of the edema, because the type of fluid which the physician might give might deteriorate the edema and might deteriorate the pathological status of the patient and might put the patient at risk of increased morbidity and mortality if the fluid and type and amount not properly selected by the healthcare provider in charge of the case. This is very important to remember in the management. The intravenous fluid therapy in patients with cerebral edema. Also, sometimes we can give medicines like corticosteroids might help to decrease cerebral edema, especially cerebral edema complicating traumatic brain injury or complicating tumors, that's in trauma and in tumors causing edema. Steroids sometimes may help to relieve and decrease the edema, especially dexamethasone, intravenous shots, which is repeated as required. Also, treatment of the underlying cause, as I mentioned, is very important. In patients with acute mountain sickness or high altitude cerebral edema, they should follow certain rules in order to decrease the possibility of hypoxia and hypoxic brain damage and cerebral edema while they are attaining the high altitudes, especially after a level of 8,000 feet above the sea level. At that level or at that altitude, the possibility of brain edema might be higher. That's why they should carry some sort of oxygen therapy with them and oxygen micro chambers to prevent the development of cerebral edema in such patients. So this is as regards oxygen, as regards hypothermia, as regards the intravenous fluids in the treatment of cerebral edema. Of course, in infections of the brain with cerebral edema, giving the appropriate antibiotics or antivirals or antimicrobials might help to decrease the and combat the infection and decrease the cerebral edema. So here, treatment of the cause. Also in patients with acute severe hypertension, giving the intravenous antihypertensive medications like hydralazine or aprezoline or some other medications, especially intravenous beta blockers. They might help to decrease the cerebral the hypertension and to relieve and decrease the cerebral edema. Also, we might give loop diuretics, that is furosemide or Lasix, as intravenous shots, 40 to 80 milligram IV shot to be repeated every half an hour as required and according to the patient's clinical response. So these are different medications which can be used also in hypertensive encephalopathy with hypertensive cerebral edema. Selection of the appropriate drug is very important to avoid further complications and to avoid further deterioration of the cerebral edema and its effects on the brain function and the life of the patient. Thank you so much, and I hope that all of you had made it valuable knowledge listening to this presentation about cerebral edema in clinical practice, causes, mechanisms, and management.